Coming to history of present illness, patient was apparently all right 4 months back. To begin with, he noticed a small growth over the right side of tongue, approximately zero point 0.5 to zero point 0.5 centimeter in size, as told by the patient, located close to the tip of the tongue. It was insidious in onset and initially ignored by the patient as it was painless and did not interfere with chewing. Later, the growth increased in size, reaching its current size of around 3 into 2 centimeter over the past 4 months. It was associated with discomfort while eating. History of excessive salivation was present. There was no history of pain over tongue or any ear pain. There's no history of halitosis, bleeding from the swelling. There's no history of difficulty in mouth opening, any tongue movements, or swallowing or speech difficulty. No history of recent dentures, sharp tooth, or any trauma to the tongue. No history of recent onset of loosening of teeth. No loss of weight. There is no history of any other swellings in the neck. No history of fever, cough, or breathlessness. Patient is a chronic alcoholic since 40 years. He has approximately taken a quarter per day of whiskey. Chronic tobacco chewer since 25 years in form of gutka, 4 to 5 packets per day. No history suggestive of high risk behavior. Known hypertensive since 30 years on medication. Coming to past history, he is a known hypertensive since 30 years on medication. No other comorbidities. No history of similar complaints in the past. No history of any dental extractions or other surgeries in the past. No history of cancer-related deaths in the family. Coming to personal history, patient consumes a mixed diet, has a good appetite, regular bowel and bladder habits, adequate sleep. He's a chronic alcoholic, taking about 180 of whiskey per day since 40 years. Chronic gutka chewer since 25 years, around 4 to 5 packets per day. He's a non-smoker. Coming to the summary, he is a 61-year-old gentleman presented with painless growth over the right side of front of the tongue since 4 months, associated with excessive salivation and discomfort while eating. He's a chronic alcoholic and tobacco chewer with no history suggestive of high-risk behavior or any distant metastasis.
Arpit, can you go to the first slide, please? No,
Yes,
before
sir.
going to the examination.
Yes.
Yeah. Yeah, next slide.
Yes. Yes.
So you mentioned growth
Yes.
over the right side of tongue for the past 4 months.
Yes, sir.
So can you just explain the exact words what the patient used, whatever language it is?
He has told in Hindi that he has got a like chala over the right side. Like in Hindi, you call it like a bump or like an ulcer kind of thing.
Yeah, you mentioned now the word ulcer.
Yes.
So that is the catch here. So never tell as a growth.
Okay.
So actually
Okay.
it is an ulcer which
Yes.
grew.
Yes, sir.
Okay, so whenever
Yes.
you have mentioned in the summary, there is no history suggest of metastasis in the final word.
Yes,
So that
sir.
means you are considering some growth which is malignant.
Yes, sir. Yes.
So almost 99% of malignancies in tongue will start as an ulcer only.
Yes,
And
sir.
never starts as a growth. So
Yes.
here the thing is, if you are mentioning it as growth, it can be anything.
Yes.
Benign
Okay. Got it.
papillomas and sometimes minor salivary gland tumors. So
Yes,
it
sir.
is always an ulcer. So you keep
Better
that
to
word
do.
as an ulcer.
Yes.
And can you go to the next slide, please?
Yes.
And it's fine. Next slide.
Yes.
Next slide. Yeah, you mentioned about this chronic alcoholic and chronic tobacco chewer.
Yes,
So
sir.
after that, you mentioned no history such as high risk behavior. He already
Yes.
has two high risk things. What do you mean by the third point?
Sir, like in cases of syphilis or human papilloma, like any history of any sexual high risk behavior, sir.
Okay, you can specifically mention that instead of mentioning like this. If you mention it blandly, here high risk means being an alcoholic or being a tobacco consumer
Yes, got
itself
it.
is a high
Yes.
risk behavior,
High
very
risk
high risk
behavior.
behavior.
Yes.
So you
Yes.
can mention that. Yeah.
Okay.
So any other questions on history, sir? Other examiners?
Yes.
Arpit, what are points in the history which are
Yes.
suggestive that you may be thinking about a malignancy and not about any other ulcer?
Sir, firstly, going to the history of present illness, sir, the ulcer, as Sir had said, the ulcer was initially small in size and over the past 4 months, it has progressed significantly to increase in size, and it was associated with history of excessive salivation, like which meant or which was suggestive that patient was having difficulty in like swallowing. No, not difficulty in swallowing. Sir, first of all, his age, sir.
Okay.
Yes, sir. After that, male belonging to a low socioeconomic status background.
Okay.
And coming to the high risk behavior, as sir had told, he is a chronic alcoholic and a chronic tobacco chewer, which like points more towards the malignancy side, sir.
Is it painlessness bothering you more?
Yes, sir. Painless swelling, which is painless ulcer, which is present, sir.
And there are two of the habits. Which one is bothering you more? Alcohol or tobacco chewing?
So tobacco chewing and alcohol, sir, because alcohol can also it acts as a solvent for the carcinogens to dissolve better.
So just quickly tell us then how tobacco leads to this particular changes.
Sir, tobacco usually it causes like breach in the epithelium, sir, and as the carcinogens are released, and when the patient is also taking an alcohol, it like goes for an synergistic effect, and as the tobacco is an irritant and alcohol is also an irritant, both of them together combined can cause uh, more chances of malignancy, sir, as the alcohol dissolves the nicotine.
Okay, you are worried about irritant effect of tobacco more or something which is taken along with tobacco?
Tobacco and beetle nut.
Lime.
Yes, slake lime. Yes, sir, slake lime.
That causes more of irritant effect. And then
Yes.
nicotine, it nitrosamine compounds,
Yes, sir.
which causes as a carcinogen effect.
Yes.
Okay, so there are few of the negative history what you have mentioned. Can you go to your
Yes.
page of negative history once?
Yes, sir.
So can you quickly tell us what all significance? Why you ask all this negative history one by one?
Sir, for history of pain over the tongue and ear pain, they can be a referred ear pain, sir, due to the lingual nerve involvement, which which causes through the auricular temporal nerve can give a referred pain to the ear, sir.
Okay.
And for history of halitosis, sir, patient will have bacterial overgrowth for which, the patient can be having foul smell from the mouth, which is called halitosis. And history of difficulty in mouth opening, tongue movements, or swallowing, if the involvement of muscles of the tongue are there, and if there's any extensive involvement of the tumor to the floor of tongue, mouth, and all. There'll be difficulty in mouth opening, and any history of dentures or sharp tooth or trauma to rule out any aphthous ulcers, sir, which can be caused traumatic aphthous ulcers. No history of loss of weight I've mentioned to check for malignancy, sir, and any history of neck swellings, so that if there's any cervical lymph nodal involvement, sir.
Okay, so tongue movements are basically because of, as I told, tongue muscles might
Yes,
have been
sir.
involved. It may lead to ankylosing.
Yes, sir.
But difficulty in opening mouth, generally it is because of
Due
a
to
TM
the
joint involvement.
EMJ joint, sir. Yes, sir.
No? Rather
Yes.
than floor of a mouth.
Yes, yes.
Fine.
And Christmas, yes.
Fine, we can continue.
Yes, sir. Sir, should I proceed, sir?
Yeah, you can continue. Examination.
Yes. Okay. Coming to the general.
Just a second. I'm just seeing whether you have mentioned any previous history of surgery here. You have mentioned that anywhere here?
Yeah, in the past histories, I've mentioned any history of dental extractions or any other surgeries in the past.
Okay. The most important surgery history is any history of previous biopsies.
Yes, sir.
So, surgery over the tongue. So that
Yes.
has to be mentioned. Whether if you are not
Yes.
mentioning also, if the discussion is going on in that way, you can mention, because
Okay.
most of the times these patients will present with the pre-malignant lesions.
Yes, sir. For
So
which
that's more
previous
important.
biopsy must have been done. Yeah.
Yes, that is more important. Okay, you can go ahead. Yeah.
Yes. Thanks.
Can you quickly tell these lesions, pre-malignant lesions?
Sir, they can be divided into three, sir: high risk, intermediate, and low risk, sir. In high risk, erythroplakia, leukoplakia, and hyperplastic, chronic hyperplastic candidiasis, sir. Coming to intermediate risk, they can be varicose lesion, not coming to intermediate risk. Syphilitic glossitis and submucosal fibrosis, sir. And then coming to low risk, it can be lichen planus and siderogenic glossitis. Discoid systemic lupus erythematosus, sir.
Okay.
It is discoid systemic lupus erythematosus.
Uh,
That's how we just get into trouble suddenly.
Right.
no, sir.
It's SLE and DLE. Both are different, yeah.
Yes,
It's
sir.
Yes.
DLE, discoid. Yeah,
Discoid
not
lupus,
systemic.
sir. Yes, sir.
Okay.
Yes,
Lupus
sir. Yes.
There is someone asked about why fever you have asked in the questions.
History of fever, sir.
Yeah, why you want to know the history of fever? Someone asked in the comment section.
To rule out tuberculous ulcers, sir. Any tuberculous ulcers, sir, which can present with like any
Maybe
history of TB, sir, basically.
So, okay, since you are mentioning about TB, I'll just ask you this question. So, what was the most commonest manifestation of tuberculosis in head and neck region?
Cervical lymphadenopathy, sir.
Cervical lymphoma is most commonest. How many cases of tubercular tongue ulcers have you seen?
Not like I have not seen.
No, I have not seen anything all these years.
Yes. Yes.
So, you can keep this as DD, but as a last
Yes.
stage.
Okay. Yes.
maybe secondary infection feels better for fever if you mention.
Any case of any immunocompromised state, sir. Okay, sir.
No, not only in
Second.
immunocompromised, most of the people, as are told, with chronic ulcer, long-standing ulcer, so
Yes,
they
sir.
will have sepsis,
Secondary
sometimes
Secondary.
secondary infection, flora of mouth infection. There is something called Ludwig's angina. Have you heard of the
Yes.
term Ludwig's angina?
Yes,
The
sir.
localized cellulitis of the flora of mouth. So
Yes,
those
sir.
people can present with fever.
Okay.
So you
Yes.
can mention fever for those reasons and need not mention about tuberculosis. If they ask
Okay.
repeatedly, you can mention tuberculosis as a last option.
Okay, sir.
Okay.
Yes. Coming to general examination, I have examined the patient in a well-lit room with adequate light after taking due consent while maintaining adequate privacy. Patient is conscious, coherent, and cooperative, well-oriented to time, place, and person. Is moderately built and nourished with ECOG score of 0. Patient is afebrile. Pulse rate is around 78 per minute, regular in rhythm, normal in volume. Blood pressure is 140 over 80 millimeters of mercury in right arm in sitting position. Respiratory rate is 16 cycles per minute. Coming to local examination, I have examined the patient in a sitting position with me sitting in front of him in a room with adequate lighting. Coming to the inspection, mouth opening is adequate. There's 3 fingers inter-incisor distance is noted. There's no halitosis. Lips, commissures, buccal mucosa, gingival-buccal sulcus, retromolar trigon are normal. Coming to teeth, there's tobacco staining noted with poor dental hygiene. Caries are also noted in caries tooth is noted in the right third molars, left second and third molars. And coming to gums, tobacco staining is noted. Coming to tongue, is in midline. There's no deviation of tip or protrusion of tongue. A single exophytic proliferative growth of size around 3 into 2 centimeters noted over the right lateral border of anterior two-third of the tongue, predominantly involving the ventral surface, extending onto the dorsum of tongue anteriorly 0.5 centimeter from the tip of the tongue, 2 centimeter and 1 centimeter away from the midline on dorsal and ventral aspects respectively. Surface appears to be irregular. There's no discharge or bleeding from growth. Surrounding area appears to be normal. There's no visible erythema. Rest of the dorsal and ventral aspects of tongue and base of the tongue is normal. There's normal movements of tongue are noted. Coming to floor of mouth is normal. Palate appears normal. tonsil and fossa appear normal. There's no other premalignant lesions noted. There's no other swelling noted in the head and neck. This is the clinical picture of the ulcer.
Next slide, please.
Yes. Coming to palpation, all
Okay,
inspect.
shall we
Sir.
finish this thing? Inspection.
Sir.
Let's go.
Yes.
Yeah.
Yes.
So before that, general. So what is
Yes,
ECOG?
European cooperation of and group, sir.
European
Cooperation, sir.
cooperation?
Group, sir.
No, you have to refer it. What is it?
Oncology group, sir. Sorry.
Yeah.
Yes, sir.
You should be well versed with everything, okay?
Yes, sir.
Okay, coming to the local examination, you mentioned about no trismus. And
Yes,
you inserted 3 fingers into its mouth in
yes,
inspection. In inspection, you would
yes.
like to? So inspection always mention 3 fingers in the palpatory part. You can.
Okay.
Yeah, that
Yes.
has to be mentioned later. Okay. And
Yes.
go to the next.
Yes.
Next. Yeah.
Yes.
So this page. So surrounding area appears to be normal, no visible erythema. So
Yes,
here
sir.
itself, what I am very much interested is,
Sir.
immediately after mentioning about the growth, you have to mention whether there is any surrounding pre-malignant lesion. That is more important here.
Yes, sir.
So that is going to help me in planning the treatment.
Yes, sir.
So you mentioned that, but you mentioned in the last page.
Later part.
Yeah, that has to be mentioned here.
Yes.
And next.
Yes.
So you mentioned about base of tongue. So what is base of tongue?
Base of tongue is base of tongue comprises of posterior 1/3 of the tongue, sir.
So can you see it in inspection?
No, sir.
So it's not possible. So never mention about base of tongue. Okay, so you mentioned.
Yes.
No, go to the rest of the dorsal and ventral aspect of tongue normal. That's enough.
Yes.
Never mention, because base of tongue is always a palpatory finding.
Yes. Okay. So
and also you mentioned about palate normal. So you can mention soft and hard palate normal.
Yes.
So in mentioning about the trismus, you can mention that I am able to see hard palate or soft palate or uvula like that. Start mentioning these things. Okay.
Yes.
Yeah. Okay. Any other questions, or we can go ahead, sir?
You mentioned about there was excessive salivation, but there is no pooling of saliva which is mentioned in your inspectory finding.
Yes, there were.
In history, there was excessive salivation you mentioned, no?
Yes, sir. Like at the time when I was examining, there was like not much, sir.
Okay.
But I'll mention, sir. But there was little pooling of saliva which was noted, sir.
No. Don't mention that just because we asked. What is the reason for excessive salivation?
Due to like inability to swallow, sir, properly due to the involvement of muscles of tongue, sir.
Is it so? Okay. So what may be the reason why he has not have that saliva? Now, when you examined?
Because probably he is spitting.
He spitted it out.
Yes, sir.
So then frequent spitting of saliva should be a very important
history finding.
Why?
So that when a patient has repeated history of spitting of saliva, that means that the saliva is getting cooled and he's not able to swallow and he's spitting it, sir.
Yeah, you are telling me the explanation for spitting of the saliva. Can you tell me what is the other important differential diagnosis here? Why he is not able to swallow it?
Because involvement of any minor salivary glands, which are...
No. These are all imaginary explanations. So what is meant by field cancerization?
Field cancerization is when the lesion occurs, the adjacent areas are also getting involved, sir.
It's only the adjacent area?
Exposure of area to the carcinogen, sir.
Yes, you are moving in the correct direction. Explain it fully.
Exposure of area to the carcinogen, which can involve the upper aerodigestive tract.
Exactly. So the entire upper aerodigestive tract is under risk for developing malignancy. So the most commonest organ, if involved, which will cause frequent spitting of saliva, is carcinoma esophagus. So patient may be having synchronous malignancy of esophagus also. So that's why that history is very, very important. Okay.
Yes. Yeah. Okay. Coming to palpation, all the inspectory findings are confirmed upon palpation. There's mild tenderness noted over the ulcer. A single exophytic proliferative growth of size 3 into 2 centimeters noted over the right lateral border of anterior two-thirds of the tongue, predominantly involving the ventral surface extending upon to the dorsum of tongue, anteriorly 0.5 centimeters from the tip of the tongue, 2 centimeter and 1 centimeter away from the midline on dorsal and ventral aspect respectively. There's minimal induration noted at the base, not extending significantly beyond the palpable margins of the growth. The ulcer doesn't bleed on touch. There's no sharp or loose tooth felt. Base of the tongue is normal. Rest of the oral cavity is normal upon palpation. Tongue sensations are normal. Single palpable lymph node of size around 1 into 1 centimeter noted in the right submandibular region, which was firm in consistency, mobile and non-tender. There were no other palpable lymph nodes. A systemic examination, CVS, S1 and S2 were heard.
Arpit, let's go to the previous slide. Yeah.
Yes.
So you mentioned about next slide.
This one. Sir.
Yeah.
Yes.
You mentioned about tongue sensations are normal. What does that mean, and what are the things you checked?
Tongue sensations for like the anterior and posterior basically it's to check for sensory nerve involvement, sir.
Which sensation you want to check? Test?
The
sensation is what?
What are the sensations you checked and how you checked them?
Both, sir, taste and temperature.
No, how did you check? How did you check taste?
Like giving him.
No, did you really give him, or you're just telling? Or did you really give him?
No, I have not done that, sir.
No, you have not done it.
Yes.
So you're telling it as routine.
Yes, sir.
Is it mandatory? Is it needed? Is it going to change the management, or is it giving you any extra information? Tongue sensations?
It can tell us about the sensory nerve involvement, sir.
Okay, same ulcer, same location, sensory nerve is gone. Another thing, same without sensory. How does the management differs in both the cases?
No much change in the management, sir. Actually, with the tongue sensations, like.
No, from where you got this idea, or is there any template which you are following, or you routinely in your college you follow these tongue sensations?
No, sir. Actually, it was mentioned in a textbook which I had referred, sir.
Okay, because tongue sensation, there are a lot of things. Special sensory.
Yes,
what is special sensory? In special sensory itself, we have 4 different.
Yes,
and
sir.
there is one 5th sensation also now, recently added. And general sensory, you have proprioception is there, vibration is there.
Yes, sir.
Pain is there, temperature. It's not possible to.
Yes,
do
not possible to assess
yeah.
everything. Yes.
So
better not.
Go back.
Yes.
So here, what you have to do mention is you mentioned about the sensory part. Actually, what you should have mentioned is the motor part. So what is the motor nerve?
Motor nerve, which
no, what is the what is the motor nerve of tongue? That's all the hypoglossal nerve. So if the hypoglossal nerve is damaged, what will happen? One side damaged, what will happen?
There'll be a deviation of the tongue, sir.
You know deviation of the tongue. Now you don't know whether to the same side or opposite side, correct?
Deviation of the tongue to the same side, sir.
Same side.
Yes, sir.
Okay. So what will happen to the opposite side? So in the tongue muscles will become flabby. So it is an element palsy or a human palsy. Element means lower motor neuron palsy or upper motor neuron palsy. Hypoglossal palsy is.
Hypoglossal palsy is supposed to be a. LMN palsy, sir.
It's neither of the both. It is bulbar. Okay.
Oh, bulbar palsy. Yeah.
So that muscle will go for palsy. When the palsy is initiated, the muscles will be flabby. So you will be palpating the muscles, which will be flabby. So there is no muscle tone at all. So that is the most important palpatory finding. Whether there is any loss of tone of the glossal muscles, that is the tongue muscles. So that has to be mentioned. So this sensation, that is not needed and that is not going to help. But the other thing, if there is a hypoglossal nerve involvement, it shows it is an aggressive lesion. You can have PNI, that is perineural involvement of the hypoglossal nerve. So that is there. Okay. So that is an extensive disease. It's a locally advanced disease. So that is an extra information. That's a very important extra information you are getting out of it.
Yes.
Yeah. Can you go to the next in the same slide? Same slide. Yeah.
Yes.
So here you mentioned something induration. What does that mean? Induration means what?
Due to the involvement of hypoglossal nerves, sir.
So induration will come even before the hypoglossal nerve involvement. So induration is a local tissue response to the malignancy. It is
spread of the.
It is actually the margin of the malignancy starts at the margin of the induration only. So it is not the ulcer which is the margin of the tumor, but it is the induration. So always the lesion which you inspect will be bigger when we palpate it. And the management depends upon the palpatory findings only and not the inspectory findings.
Yes.
Okay, and we have to give the margin based on the palpatory induration margin and not on the inspectory margin. Okay, next slide, please.
Can I just ask one question?
Yes, sir. Yes, sir.
So, what is the commonest finding that is missed in a CA tongue on palpation? What is the commonest finding that is missed by most of the people?
Commonest finding missed by. Sir, it can be it's a rise of temperature.
No. It is a palpatory finding because you see, whenever any patient comes as a CA tongue, mostly they are present in the anterior part or lateral border or posterior part.
Yes.
The commonest thing people miss is once you see the lateral part, people just take it as a this is the only lesion and they don't do the palpation complete. So what you have to do is when you are doing the palpation, you should palpate the whole tongue, starting from the tip to the base of tongue and from the left border to the right border. Completely. And on the ventral surface also. Because you see, sometimes there is, because of field cancerization, there may be one or two lesion, and most commonly missed is the base of tongue lesion.
Yes.
Which is only a palpatory finding because it is not visible on inspection when you are viewing from the front. The only visibility can happen is only during a direct laryngoscopy. So it is very important in the OPD. Most of the places what we see is you just write the lateral border of tongue on the left side. But when you ultimately go to the OT, when you are trying to do the resection, you find it is extending to the base of tongue, which might become inoperable on table. So it is always very important. The palpatory finding is the most important. As sir was telling, that palpation margin is always bigger than the inspection margin. And commonest site of missing the tumor is at the base of tongue.
Base of the tongue, yes.
Yeah, you can proceed.
Yes, thank you, sir. So can I proceed?
Yeah, you can go ahead.
Systemic examination, S1 and S2 were heard. Respiratory examination, air entry was, both the lungs were clear, bilateral air entry was present. Per abdomen, it was soft, non-tender. There was no organomegaly or ascites, bowel sounds were present. Coming to CNS, there was no focal neurological deficit which was noted. Coming to summarize the case, a 61-year-old gentleman, chronic alcoholic and gutka chewer, presented with painless progressive growth, ulcer over the right anterior two-third of the tongue since 4 months, associated with excessive salivation and discomfort while eating. Upon examination, a single exophytic proliferative ulcer of size 3 into 2 centimeter noted over the right lateral border of anterior two-third of the tongue, predominantly involving ventral surface extending onto the dorsum of tongue anteriorly 0.5 centimeter from the tip of the tongue, 2 centimeter and 1 centimeter away from the midline on dorsal and ventral aspects respectively, with irregular cauliflower-like surface and mild induration at the base, and single palpable mobile lymph node of size 1 into 1 centimeter, firm in consistency and non-tender in the right submandibular region.
So what is important here is
Sir.
the node crossing the midline.
Yes.
Yeah, that is a very important finding.
Yes.
Yeah.
My provisional diagnosis would be carcinoma of right lateral margin of anterior two-thirds of the tongue with a palpable level 1B submandibular lymph node on right side of the neck with TNM staging of T2, N1 and M0.
So why do you call it is a carcinoma?
Sir, due to the findings where firstly it's a painless swelling,
No,
sir.
first, First, understand my question. I am not asking why you called it as malignancy.
Okay, sir.
I am asking the question why you called it as carcinoma. Malignancy is a clinical diagnosis. Carcinoma is a histological diagnosis. Why are you calling it as carcinoma?
Correct.
Oh,
Correct.
okay. Yes. Ulcer of over the which probably of malignant origin, I should have mentioned, sir.
Okay, you could have, so if the differential diagnosis, you can mention it as carcinoma.
Yes, carcinoma. I got it, sir.
So what is the term used? There should be a very specific term used for this.
Sir, the term could be
It is called as ulceroproliferative growth.
ulcer-proliferative growth of yes, got
of
it.
size, whatever you mention.
Yes.
So in the differential diagnosis, you can mention because
it
it is ulcerative. So probable may be a carcinoma, and
Yes.
because this having the then the histopath will come.
Yes. Got it.
Yeah.
Yes.
How do you know? How did you know this is level 1B node and it is N1 on what criteria?
Sir, on palpation there was
N1 node. How do you classify?
only it was involving only ipsilateral side, sir, and there was only one lymph node which was less than 3 centimeter size, which was palpable, sir.
And in which triangle this was present? You are writing 1B node.
Yes.
So 1B suggests which triangle? Do you know triangles of the neck?
Yes, sir. Submandibular, sir.
So what? Submandibular.
Yes.
So what
Yes.
are the other triangles of the neck?
Sir, level 1 is submental, 1A is submental, 1B is submandibular, sir. 2, 3, 4 are upper, middle, and lower digastric, sir. 4 is level 4 is
How do you differentiate?
pardon, sir?
Level 2, 3, 4. How do you classify?
On the basis of hyoid bone, sir.
Arpit, are you able to understand why sir is asking this question repeatedly again and again?
Sir.
So you mentioned about hyoid bone, no?
Yes, sir.
So all these levels.
2, 3, 4. So 2, 3, 4. How do you make it 2? What is 2? What is 3? What is 4?
Upper jugular, lower middle jugular, and lower jugular, sir.
Yeah, but there must be some landmarks, na, anatomical.
Digastric carotid triangle.
How it can be carotid?
No, not carotid, sir.
What is other names of it?
This is very fundamental.
Cricoid cartilage, sir.
Then lower part below cricoid.
Yes, sir. Below cricoid, sir.
I don't think. I think you have to read. 2, 3, 4 landmarks are totally different. What you told is they are not the landmarks.
I'll just refer, sir, once.
Yeah, you because this is a very fundamental question.
Yes.
Okay.
Yes, sir.
So this is T2N1.
Yes, sir.
M0. How
Yes,
do
sir.
you know it's M0? Did you do any staging workup?
Yes, sir. Staging workup has been done, sir.
What staging workup?
CT scan of the neck and chest X-ray was done, sir. Chest X-ray was normal, sir.
Okay.
And this
And
is the
CT chest is not required?
CT chest is required, sir. Like we have got it done, sir. Like it was also normal, but I don't have the report right now, sir.
Okay. And
Yes.
that's okay. So you have
Yes.
staged and what is your plan of treatment?
Sir, I'd like to go ahead with a wide local excision with modified radical neck dissection, sir.
Okay. So
Yes,
again, coming wide
sir.
local excision,
This is
you
the
have
one,
a
sir.
biopsy, na, proved.
Yes, sir.
Already biopsy proved.
Yes, sir.
What does the biopsy say?
It is feature suggestive of varicose squamous cell carcinoma, sir, with depth of invasion of around 8 mm, sir.
Invasion is 8 mm.
Yes, sir.
What does it signify? 8 mm.
Sir, depth of invasion is it T2, sir.
Have you ever read the HSCC or TNM classification?
Yes, sir.
What does this signify?
Sir, in T1, T2, it can be either like between 2 to 4 and like between 5 to 10 mm of uh,
Invasion, depth of
invasion.
invasion. Yeah.
Yes.
So how you classify?
Sir,
2 to 4 and 5 to 10. Is
sir,
there any importance to this depth of invasion?
yes, sir. Like if depth of invasion is more than 10, and even if the size of the ulcer is very small, we consider
Uh,
it as T3, sir.
Correct. And
Yes.
if it is more than 4, what does it indicate?
The depth of invasion is more than 4.
4, what does it indicate?
Uh, we have to. It is belongs
So,
to.
histopathologically,
Yes,
they
sir.
are considered as poor risk patients, more than
Yes.
4.
Okay,
So,
sir.
all of them will need radiation, more than
Yes.
4.
More than
So,
4.
that is why this new classification came
Yes.
on depth of invasion.
Yes, sir.
I think Sir can go with other questions.
Yes, sir.
Is it indication to go ahead with a neck dissection? Suppose there was no lymph node submandibular, you have more than 4 mm of invasion. Is it indication to go ahead with a prophylactic neck dissection for the case?
We can post-operative, like we can plan for a selective supraomohyoid neck dissection, sir.
What do you mean by prophylactic neck dissection?
Uh, uh, to prevent further uh, to prevent this uh,
At the time of surgery,
sir.
for the primary thing, you are doing a wide local excision.
Yes, sir.
Okay. How do you know that there are no microscopic cells in the lymph nodes? You have any method to know?
Sir, we could do a sentinel lymph node biopsy.
But in head and neck cancer, is it very popular?
No, sir.
Then what Sir is asking is
Yes,
the
sir.
answer to your question. That because of microscopic cells, you don't know,
Yes,
sentinel node is uh, not applicable in head and neck.
head and neck cases.
So always a prophylactic neck
Like this.
dissection is done in all carcinoma tongue,
Yes,
whatever may be the depth of invasion.
yes,
Because if all have burnt fingers, to have a lymph node, at a later stage when people only do the wide excision and leave the patient like that. Because microscopic disease cannot be known. So
Yes.
all patients of carcinoma tongue,
We have to go ahead with the
irrespective of the
yes. Sir, your audio is like
depth of invasion, they all composed are there, Dr. Ibrahim.
oh. Okay, sir. Got it, sir.
Particularly more than 4 mm considered a strong indicator that
Strong
there may be
indicator.
some that lymph nodal activity.
Yes.
You should go ahead with a neck dissection on the opposite side also, prophylactic.
Yes.
No, only one comment, if you permit me.
Yes, sir.
Actually, I'm surprised from where they have measured depth, because 8 mm depth of invasion, we cannot call it as varicose carcinoma. It is infiltrative, no? Usually, the depth is measured from the basal layer of adjacent normal epithelium.
Yes, sir.
My doubt is probably they have measured the thickness, not the depth.
At tumor thickness.
You should in this case, I will get second opinion, or I will discuss with pathologist.
Okay, sir.
Yes, sir. Yes, sir. Even I was about to ask that question only, because I just wanted to know from where he will take the biopsy. So that is the most relevant question here for an MS postgraduate rather than main management.
Yes, sir.
So Arpit, can you just tell me where you will take the biopsy? The lesion is on the dorsal side and ventral side. Ventral side, it is more. Dorsal side, it is less. Where you will take the biopsy now?
Sir, the ulcer along with the part where the normal mucus is also involved, sir.
No. The question is very simple. Dorsal or ventral?
Ventral.
Why?
Due to more because of like the ulcer is more prominent over the ventral aspect.
No, ulcer is ulcer only. Whether it is ventral or dorsal, ulcer is ulcer only.
Yes.
So when Rudra sir was telling you the most important finding, he told, what is the most important finding in the CT, or what is that? Something. It did not cross the midline.
Yeah, did not crossing the midline. Yes, sir.
So when you take the biopsy from the ventral surface, you'll be taking from the junction of normal and abnormal tissue, normal and malignant tissue. So you'll be taking a biopsy closer to the midline.
Yes, sir.
So you should never do that. So you should take from that part which is well away from the midline.
Midline, yes, sir.
So here in this case, it is more on the ventral side.
Hence,
so
that's
always
the
better
ventral
to take
aspect.
from the dorsal side in this case.
Okay, sir.
And what will be the exact location? Can you tell me?
From the edge of the ulcer, sir.
It's ideally, if you want to tell, it is a wedge biopsy from the edge of the ulcer.
Wedge biopsy from the edge of the ulcer.
It should include both the malignancy as well as the
normal tissue.
Because you are going to take the normal tissue, the next margin of excision is going to be including the biopsy site also.
Biopsy site.
You have to include it in the dorsal side here.
Yes.
And as Subhaya sir was telling,
yes,
they have mentioned in the biopsy depth of invasion is 8 mm. So that is not possible here, because we have not sent the entire specimen at all.
Yes, sir.
So it is from the biopsy side. So you should very well have a discussion with this thing. So the depth of invasion 8 mm means the only information what you are having is depth of invasion is more than 8 mm. That's all.
Yes, sir.
Even T3 also now here.
Yes.
Suppose in the main area, if it is about 12 mm invasion depth, it automatically becomes a T3 now. T3, sir. Yes. So it will in fact upgrade or upstage the tumor. Yes. Okay, and here what I want to tell you is Rudra sir was again and again asking you about levels. Yes, sir. You mentioned it. It is hyoid and cricoid, everything. But hyoid and cricoid are not easily inspectable or palpable landmarks. So these surgical levels are always only for the surgeons who are going to do the neck dissection. Yes. So for clinical findings, you have to mention not as levels. You can mention as with submandibular gland or submental gland or upper jugular or mid jugular or lower jugular. Yes, sir. If you mention about levels, you will be facing these questions. Yes, sir. Okay. Yes. And coming back to Rohit sir's question. So you
Yes.
were he was asking what will you do, the minimum, because there's no
Yes.
central biopsy. So what is the minimum surgical procedure you will do for a neck, even if there is an N0?
Selective neck dissection.
Yeah, selective neck dissection. So what are the things you are? What are the nodal stations you are going to select here?
1, 2, and 3, sir.
Why?
Because these are the draining nodes, like the ones, the primary draining nodes for the tongue, sir.
Yes, it is the primary nodal areas of the anterior two-third of tongue. Okay, your answer should be specific,
Yes.
and every answer should be backed up with scientific explanation.
Yes, sir.
So what is that called? 1, 2, 3. What is that selective neck dissection is called? Some terminology is there.
Supraomohyoid.
Yes, excellent. It is called supraomohyoid neck dissection, SOHND. So if you are including the level 4 also, it is called ESOHND, extended supraomohyoid neck dissection.
Supraomohyoid.
Level 1A, 1B, 2A, 2B, and 3. And in extended, you will remove 4 also.
4 also.
Yeah.
Yes.
So what are the things you would like to see in the final histopathology? You have done the surgery. So you have done a wide excision, and you have done neck dissection also.
Yes.
So here in this case, what neck dissection you would like to do? There is a palpable node is there. So it's a SOHND, ESOHND, or a modified radical neck dissection.
No, I'd like to go ahead with modified radical neck dissections.
Okay, actually, when you are explaining or telling, no, there is no like here. I will do. I would like to. It is not
go ahead with
likes and dislikes. You have to just tell what you're going to do. That's all.
Yes, I'll go ahead with modified radical neck dissection.
Why?
Due to as there is nodal involvement is present, and the
so I am telling that is a inflammatory node because of chronic infection. There is some chronic inflammation and infection which is causing that enlargement of that node.
Yes.
So how will you convince me for a MRND instead of an SOHND?
Sir, before prior, I'd go for a FNAC of the lymph node, sir.
Okay, you can do an FNAC of the lymph node.
Yes, sir. Ultrasound guided because it's a small.
Okay, so you have done an MRND as well as this thing. So how do you send the specimens after an MRND? That is modified radical neck dissection. How will you send the specimens?
We mark them.
How do you mark them? So for
did you speak about what are the type of neck dissection and the details? What do you mean by modified radical neck dissection?
Pardon, sir?
Classify modified radical neck dissections.
In modified radical neck dissections, we take out all the level 1 to 5 lymph nodes, sir. And it can be 3 types, sir: sparing IJV, sparing IJV sternocleidomastoid, and the third one, along with sparing IJV, sternocleidomastoid, and spinal accessory, all 3 structures, sir. Hello.
Yes, right.
Yes.
Yeah. So back to my question, Arpit, you can just tell me, how do you mark? So neck dissections you don't mark, you dissect the specimen also. Okay. And separate each region separately and send it separately in different containers. So marking comes for the main specimen. There is a wide excision. No, you need to mark which is anterior, which is lateral, which is posterior, which is deep, whatever it is, for the anatomical orientation of the
lymph node
tumor for the pathologist. For the pathologist. Okay.
Okay.
So I think I'm hurrying because there is one more case for discussion.
But one basic question: how do you orient the specimen for the pathologist? Because let us say tomorrow you are on leave, you are not available.
Yes.
How will you mark the specimen so that how the pathologist will be knowing it? There is a universal way of marking the specimen.
Taking a long thread which is actual like lateral end.
Yes. Very good. Long for lateral. So long means there is something short. Short is for?
Short is for superior.
Very good. Very good.
and not superior.
So instead of a single tie, you can tie a double tie.
Double tie for yes.
Double tie for
Depth.
deep margin. Deep
So
margin.
deep
Yes.
margin. So this is a common common thing used. So if you are not even available, the pathologist can automatically mark, because this is a universal way of marking.
Yes, sir.
Whether it is breast lump or whether it is any place you are having a wide excision, soft tissue tumor, or
Yes.
a tongue, everywhere the same thing. And
Yeah.
you should always make a diagram in the histopathological form and make all the markings clear, because you see,
Yes, sir.
these are very important in malignancy, because based on this, the radiation planning will happen in future.
Yes, sir.
Depending on the margin positivity and how much close is the margin, the
Yes.
pathologist has to clear cut write the margin from the corner to there.
Yes.
So, okay.
Yes,
Yeah,
sir.
yeah.
Got it, sir.
Would you like to give any adjuvant treatment? Quickly.
Post neck dissection, need for radio based on the HP, sir, if there's perineural invasion or lymphovascular invasion, and if lymph node positivity is seen, post-operative radiotherapy might be used, sir.
Particularly your invasion also.
Yes, sir.
If it is actually more than 8 mm, apart
Yeah,
from what you are
and
mentioning,
the depth of invasion, sir. Yes, sir.
yes, that gives me adjuvant radiation for this particular patient.
Yes, yes, sir.
Which is one significant prognostic marker for oral cavity malignancies.
Prognostic marker for sir, I think
apart from stage of a disease, lymph nodal status.
Lymph nodal status of the, yes, sir.
Right?
Yes, I got it, sir.
So that's why the most important information from the final histopathology report is the number of positive lymph nodes.
Positive lymph nodes, yes, sir.
And also negative margin of excision. So these two are most important to decide on the adjuvant treatment.
Yes.
Sir, Kanagvel sir, are you there, sir? Shall we go for the next case?
Yes.
Good presentation, Arpit.
Yeah, sir. Thank you so much, sir.
Sorry, we had all surgical oncologists here. National president, state presidents, all are here. The next presenter.
Thank you so much, sir.
Thank you.
Yes.
Good evening, sir.
Yeah, good evening.
Shall I share, sir?
Yeah, you can go ahead. Yeah.
Shall I start, sir?
Yes, please.
Good evening to all. I'm Dr. Haridra from Lotus Hospital, Erode. My guide is head of the department, Dr. Ishwamurthy, sir. I'm going to present a case of breast lump. The patient is a 70-year-old female in Hindu religion, occupation by homemaker, residing at Erode, came with chief complaints of right breast lump for past 5 months. She was apparently normal before 5 months, after which she noticed a painless lump in her upper inner quadrant of right breast, which was insidious in onset and progressively increasing in size. No history of nipple retraction or discharge from nipple. No history of overlying skin changes or discoloration or ulceration. No history of axillary swelling or any other contralateral breast swelling. No history of fever. No history of recent trauma. No history of bone pain, cough, or weight loss history. Past history, no previous history of breast lump or surgeries for the breast. She has undergone sterilization surgery. She is a known case of type 2 diabetes on regular treatment. Personal history, she is vegetarian by diet, no history of tobacco chewing, normal appetite, normal bowel and bladder habits. Family history, there is no history of malignancy running in the family. Her sibling was an elder brother. And obstetric history, she attained menarche at the age of 12 years, menopause at the age of 50 years of age. She had 3 children, all of them normal vaginal delivery. At the age of first child, it was 18 years of age, and last child was 25 years of age. She breastfed all the children till 2 years of age. Summary, a 70-year-old postmenopausal female presented with painless lump in right breast, which was insidious in onset, progressively increasing in size with no symptoms suggestive of metastasis.
Can you go to the first page from the start? Yeah.
Demographic details, sir? Or
yeah, from the start, yeah. Religion is not needed actually. So she's 70-year-old. Religion we don't mention often, and occupation, she's still a homemaker. Okay, residence 0. Next slide. Yeah. So here you mentioned about the thing, but what is the most important thing you have not mentioned here? Can you go? What are the parts of the breast?
Parts of breast. Breast is divided into 4 quadrants with axillary tail of Spence.
Before proceeding,
yes,
Rita, can you say, Sir says religion is not important. If you have mentioned religion and you have any reason in particular part of the world, can you ask religion or correlate regarding breast cancer or subtype of breast cancer or hereditary predisposition? Ashkenazi Jews, what is the common type of breast cancer more common?
In Jews, sir?
A particular sect. Triple negative. BRCA12?
Yes, BRCA is common in Jews.
If at all,
hereditary carcinomas.
If at all you have any reason to ask religion, that can be the only reason. Okay.
Okay. Yes, sir. Okay.
Yeah, go ahead.
Is a present axillary tail of Spence and parts of breast. And breast is divided into 4 quadrants, sir. Upper, outer, upper, inner, lower outer, and lower inner quadrants.
Okay. Go ahead. Next slide. So yeah, here you mentioned about sterilization, no? So always mention what type of sterilization. Even hysterectomy is also a sterilization only. So what do you want to mention? How do you want to mention here?
Tubectomies.
Tubectomy or tubal sterilization?
Tubal sterilization.
They don't do tubectomies, okay? Tubal sterilization. Yes, so tubal sterilization. Yeah. Next and the next slide. Yeah. So what is the plural of children? Children is plural da. Child and children. Okay, you mentioned twice. Children's. Okay. Yeah, it is children. Yeah. So what is the importance of breastfeeding and malignancy? Cancer?
In earlier studies, it showed a decrease in incidence of breast CA in when breastfed for more than 1.5 years.
No, can you come again?
In earlier studies, it showed a significant decrease in the incidence of breast carcinoma in women who breastfed their children's for more than children. Yes, children more than 2 years.
Or child, whatever it is. Yeah. So what is that earlier study? Even it holds good even now also.
Okay.
So if the children are breastfed for 1.5 years or more, the chances?
Incidence decreases.
Decreases, okay. And here in the family history, you mentioned about one sibling, elder brother having malignancy.
Elder brother, sir?
You have mentioned about family history, one sibling, elder brother. Is it malignancy or just a family history?
No, sir, just a family history.
So no history of any malignancy or any disease in that.
In the family, no, sir.
Is he alive?
Yes, sir. He is alive, sir.
He's alive.
He
Okay.
was the one accompanied.
Okay. Next slide.
Summary.
Okay. Sir, any other questions, sir? History side?
Yes, in the history of negative history, you mentioned about a trauma, and then you mentioned about a recent trauma. So why trauma is bothering you, and that to recent trauma?
Any chances of a traumatic fat necrosis I can suspect in this patient, sir. Since old age, she does not remember any trauma. There is a chance of a trivial trauma she has undergone, has been
So
eventful.
that will not be recent one. That will be old traumas, which may lead to the necrosis. Then it will cause a little fibrosis, and then it will be presenting like a lump. Okay. So cumulatively, if you call it as, there is something called it as a Gale model of risk index for CA breast. So can you tell me what are the factors in that Gale model, which will be asking in all the patients pertaining to the CA breast? GALE, Gale model.
Okay.
You'll read and
I'll refer and come.
Fine. Okay, even because you asked about the age at the first childbirth. Sorry, like worried about that? Someone who is having age at first childbirth is more than 30. Is it bothering you?
Yes, sir.
How?
Late age, the estrogen hormones, prolonged exposure, it induces breast carcinoma, sir.
So you have, according to that index, you keep on increasing. If it is more than 30, you have 1.2. Then it is more than 35, it is 1.4. Like that, it keeps on increasing guys. Okay. And then lactation period you mentioned, call it as a cumulative lactation period.
Okay.
Minimum 6 months, best is 2 years, like that.
Okay, sir.
So Haridra, it is actually the unopposed continuous estrogenic stimulation which promotes cancer tumor malignancy of the breast. Okay,
sir.
Whenever you hinder that unopposed action in between with the lactation and pregnancy,
okay, sir,
it's hindered. So that's the main mechanism.
Okay, sir. Thank you.
That's how childbirth and lactation helps.
Okay, sir.
Few examiner even want to know about history of radiation early in this thing.
Yes, sir. History of previous radiation. Yes,
How?
sir.
So it's like a huge exposure. Which type of exposure is causing a problem?
She has taken one chest X-ray. That is also radiation exposure only. Is that will be okay? What type of radiation exposure you are expecting?
Any radiotherapy taken for radiation previous, like treatment for any other illness?
So what type of illness? What type of illness? So patient had a carcinoma cervix at the age of 60. She has undergone a pelvic irradiation. So is that in any way connected?
No, sir. Radiation to local site like head and neck and breast upper limb, it may has a potential risk of developing this.
No. Breast is located in chest, no? So why do you want to give a neck radiation? How it will affect breast carcinoma? So in other words, in what disease you get a chest radiation? Have you ever heard of mantle field or anything like that? So previously in lymphomas, we get chest wall radiations previously. So childhood lymphomas, if they are treated with radiation to the chest, they are at a high risk of developing breast cancer. Okay. So whenever you are asking the negative questions, most of the time the discussion will be based on the negative questions only, not on the positive, because we know you will answer the positive. So the discussion will go only with the negative. So always be prepared for the questions based on the negative findings.
Okay.
Sir, please, sir. Rohit, sir, please, sir.
Yes, sir. Continue, please.
General examination. Patient was examined in a sitting, semi-recumbent and supine position in a well-lit room after getting consent. She was average build, well-nourished in nature. No signs of pallor, icterus, cyanosis, clubbing, edema or lymphadenopathy. Her vitals were stable with saturation of 98% in room air, heart rate of 84 and BP of 130/80. Her BMI of 26. Local examination. On inspection, patient was exposed from neck to till waist with exposure of axilla. Bilateral breast was symmetrical. Right breast, there was a fullness in the upper inner quadrant. There was no visible skin changes like dimpling, satellite nodules, pudgy orange, or ulcerations present. Nipple area or complex was normal with no retraction or no discharge or no displacement of nipple. Axilla was normal and left breast and the axilla were normal. On palpation,
Can you stay at
inspectory
inspection? Just a minute. Can you go back to inspection? In skin
Yes, sir.
changes, you mentioned as a dimpling. Is a dimpling skin change? Why dimpling is caused?
It is due to the pulling of the ligament of Cooper.
Infiltration.
Infiltration.
And shortening of ligament of Cooper. So should it be mentioned as a skin change? No. It should not be mentioned as a skin change. It should be a separate finding what you are mentioning about.
Okay, sir.
Moreover, moreover, you have mentioned bilateral symmetrical breast, and in the next line itself, you are telling fullness in the upper inner quadrant.
Yeah.
So,
Right.
if it is symmetry, means both sides it should have fullness in upper inner quadrant of right and left breast. Is it so, or it's only in the right breast?
No, so only in the right breast.
So that means it is not symmetrical.
Okay.
And moreover, in normal breast itself, both sides will not be the same. So it is always there is a difference. So it is we never put that symmetrical. So you can just put fullness directly.
Okay, sir.
And as sir told, dimpling is a palpatory thing. Okay. So never put these things. And you have mentioned about even though you have mentioned no previous surgeries in the breast, it is better to mention no scars here also. You have not mentioned about scars. Because breast is one place where there are frequent surgeries or biopsies happens.
Yes, sir.
Okay, they might have forgotten. So 70 years old, they might have forgotten. Sometimes they may not tell, thinking that it is not relevant here.
Okay, sir.
Routinely asked UG question about inspection. In what positions you inspect the breast, and what is significance of these positions for inspection?
Patient should be examined in a sitting on a supine and semi-recumbent position, sir.
No. In sitting, breast should be inspected in sitting position. So what are the 4 positions in which you do it? And tell me significance of each position why you do that. You got the question?
Yes, sir.
Yeah. So first will be hands by the side. What do you want to do in hands by the side?
Hands by the side, I will look for the bilateral breast normally, sir.
We'll go for comparative elevation. Comparative elevation, basically.
Comparative evaluation. And I'll ask the patient to raise her hands and look for the symmetric equally. The breasts are moving equally, sir, by raising her arms.
What you achieve by raising the arms? 3 things. What you see in inspection when you raise the arms. Basically, now you pull the clavipectoral fascia up, right? When the patient is raising hands, you can raise the clavipectoral fascia, and now you can see the dimpling. One. Second one, you see for the inframammary ridge, any of the ulcer or lump which is hidden there. And third thing, now axilla is very clearly visible in front of you. Both the axilla will be very clearly visible. If hands are by the side, you won't be able to see that, right?
Yes, sir.
Okay. Third position.
Third position, by keeping the hands on the waist.
Why you want to do that?
Relaxing the pectoralis major muscle. Any swelling appears on keeping the hands on the waist.
Okay, so basically this is for the voluminous breast, where you want to show for lower outer quadrants, which may be hidden again. Yes, and last position?
By leaning forwards.
Very good. What do you want to see in this position?
We examine the fall of the breast equally both sides.
Yes. So is there something which is fixed to the chest wall?
Fixed
that
to
will
the
not
chest
be
wall.
falling very freely.
Okay.
Yes. What do you mean by chest wall?
Chest wall involve muscles like intercostal muscles, serratus anterior, sir.
And one more structure.
What about the ribs? Is it part of chest wall or
Yes, sir.
what?
Yes, sir. Yes, sir. Ribs, intercostal muscles, and serratus anterior muscle. Chest wall.
What about sternum? Sternum is what? What do you think?
Mediastinum.
It is also part of chest wall only.
Yes, sir. Okay.
Okay, you can go ahead. Yeah.
Yes, sir.
So
Palpation.
you are going directly to the palpation, or again the inspection returns, or you have not mentioned about the leaning forward and all. You have not mentioned.
No, sir.
So inspection is
I
over.
didn't mention. Yes, sir. Inspection is over, sir.
Oh, okay. So that's why you have to mention. That's very important, because
Okay,
only during that hand raising, no, you will see axilla,
yes, sir.
inframammary region, and also how it is attached to the pectoral fascia. Everything you'll know.
Yes.
So that has to be mentioned. Okay.
Okay, sir.
Yeah. Go ahead with palpation.
Yes. On palpation, right breast examined first. There was no warmth, tenderness. There was a solitary lump, approximately 4
And
into 4 centimeters.
sorry for interrupting. Go back to the previous one. Yeah, you have mentioned about left breast and axilla normal. So with the hand by the side or waist, whatever it is, you will not be able to see the axilla at all in inspection. So only after you mention all the 4 positions, you can mention about axilla.
Yes,
Okay.
sir.
Yeah. Next.
Yes, sir. No warmth, no tenderness. There was a solitary lump of 4 cross 4 centimeter in the upper inner quadrant, extending from 12 to 2 o'clock position. The consistency of the lump was hard. Margins were ill-defined, irregular surface. Skin was normal. There was no fixity by pinching. Mobility, there was a reduced mobility, but not fixed to the underlying muscle or the chest wall. Nipple areolar complex were normal.
So here another dimension which you have to mention here is how far the lesion is from the nipple areolar complex.
Yes, okay.
Is it close to the nipple areolar complex, or it is some 5 centimeter away? How is it?
Just abutting the areolar margins.
Okay. So it is close to the central quadrant.
Yes, sir. It was just abutting the areolar margin at 12 o'clock, sir.
Okay.
Right. In inspection, how you do this thing? 4 of the positions. Are there any rules for palpation? How you palpate breast?
We palpate with our fingers.
Yes.
4 fingers.
3. This area.
Yes, sir.
Right. Next.
Yes.
In the sitting or supine position, because that is most common mistake we have seen happens in the OP.
Supine position.
Yes,
Will
always
palpate.
supine.
Yes.
Yes. Then any other method you want to use? You call it as a clock dial method. That's why you have mentioned 12 to 2, no? So definitely
Yes,
use the clock dial method.
Yes.
And then use it with the 3 concentric circles. You palpate, you feel a consistency, and then you feel a fixity.
Okay, sir.
Right? These are the 4 rules what you follow when you go for the palpation of a breast.
Okay, sir.
Okay, so I mentioned clearly about skin by pinching of it. How you understand fixity to the breast tissue? Because you don't have fixity any other structure. That's what you have mentioned.
Yes, sir. Fixity to the breast tissue. Since it is a reduced mobility was feeling.
How you check it? How you check fixity to the breast tissue?
On moving the lump horizontally, the breast
fix the
also
breast
moves.
tissue.
Also,
Right. You fix
breast
the breast.
also moves. Sir. Yes, sir.
Right. You fix the breast tissue and then try to move the lump. And then it has a
Yes, sir.
restricted mobility, it is fixed to the breast tissue. It becomes earliest sign of your desmoplastic reaction started already.
Yes. Okay, sir.
Fine. Axilla, you're going to mention separately in palpation.
Yes, sir. Axilla next coming, sir. Axilla, there was no palpable lymph nodes, sir.
Okay.
No supraclavicular lymph nodes palpable, sir. Moving to left, normal breast. Left breast was normal, no lump. Nipple areolar complex normal. Axilla, no palpable lymph nodes, sir.
What are palpation when you do? What all the palpations you do from behind the patient? You go behind the patient and you do that. 2 of examinations. Or 3.
Lymph node examination.
Which group of lymph nodes?
Supraclavicular lymph nodes.
Very good.
Palpated from behind, sir.
Very good. Other 2 things. What you go behind the patient and check. You check for posterior axillary group of lymph nodes. Against which muscle? Subscapular muscle.
Subscapular. So yes, sir. Subscapular.
Yeah, yes. What is third thing you take for it from behind the patient? Immediately check for tenderness over the spine. Right, where you expect a metastasis. These are the 3 things which I check behind. You ask the patient to sit, go behind, and then you keep on examining for these things.
Okay, sir. Yes.
So previous slide, Haridra, previous slide.
Yes,
yeah.
sir.
So in this, so sometimes, like many times, whenever we do some palpation, so during the palpation, there may be discharges coming from the nipple.
Okay.
So it has to be mentioned. Even if it is negative also, you should mention that there is no discharge during the palpation. So what does that signify? If there is a discharge from the nipple when you are palpating the lump, what does that signify?
It signifies underlying cystic lesion.
Yeah. Which is in continuity with the lacteal duct.
Lactating
so
duct.
most of the time, ductectasias will present like that.
Okay, sir.
So that's why when Sir was telling, you have to palpate it concentrically, and we should know even from normal area also. Where there is no lump also, when you are palpating, suddenly you may see some discharge coming out. That means there is a dilated duct there. So we have to see the nipple when you are palpating, and it has to be in a regular pattern, concentric. Okay.
Okay, sir. Concentric.
Yeah.
Clockwise.
So Sir was telling about tenderness of the spine.
Yes, sir.
Why it is important in breast case?
Breast carcinoma, most common metastasis to bony metastasis is common, sir.
No, you have suddenly gave a statement now. So, what is the most commonest site of metastasis in breast cancer?
Bone metastasis.
It is lymph nodes only. Lymph nodes. Okay.
Yes, sir.
Bone is one of the common. Okay. It is not the commonest. The commonest is always lymph nodes.
Okay.
Okay. Okay. Next slide. So, palpation over. Is there any percussion there?
On percussion,
No, you have
in this patient, I didn't look for percussion in per se, sir. There was no in axillary lymph nodes were present. Percussion is valid in on palpating for internal mammary lymph nodes.
So what are what are the lymph nodal drainage areas for breast?
Axillary group of lymph nodes, internal mammary lymph nodes.
So here the lesion is on the upper inner quadrant. Where do you think the drainage will be here?
Axillary and internal mammary lymph nodes.
So there is a high chance of internal mammary drainage here.
Okay.
So whenever there is a medial quadrant growth, internal mammary enlargement is very much possible. So even if it is negative, you have to definitely mention. So how do you do that? How do you do the percussion here?
I will percuss from between the intercostal spaces, medial medially lateral to the sternum. Look for any dullness over the intercostal spaces.
There is actually the breast tissue. You are palpating. You are now going to percuss the breast tissue, but here there is a tumor. So you are going to directly percuss the tumor. Where you are going to do?
Medial to the tumor, sir.
Okay, so it is basically a enlarged parasternal dullness.
Okay.
So
Yes,
in
sir.
which spaces you would expect it to be?
Second, third, or fourth intercostal space, I'll expect internal mammary lymph nodes to be
So second
palpable.
intercostal space is between first and second rib or second and third rib?
Second intercostal space is between second and third ribs.
Yes, excellent. So you start from the second and third, from the second, below the second rib. So second, third, four, and five. So all these four spaces. That's all. And you compare it with the opposite side.
Okay, sir.
Okay. So that is mandatory. So any other things you want to do in percussion, in chest? Okay, you may be mentioning in other system examination. I hope so. So next slide.
Yes.
Next slide. So examination over. We are going to investigation, or it's still there?
No, sir. I couldn't get the clinical image of the patient, so I just added the mammogram picture here.
Okay,
sir.
we can discuss about the thing. Examination still there, or it's over?
Oh, it's a systemic examination.
Okay, okay.
Going
Go,
to
go to systemic examination. Yeah, go to systemic. Yeah.
yes. On systemic examination, cardiovascular examination was normal with no murmurs heard, and respiratory system bilateral air entry was equal with no added sounds. CNS examination, no focal neurological deficit, and per abdomen was soft, no organomegaly, bowel sounds present. On spine, no tenderness was there.
So, of all the five systems you have mentioned, which is the most relevant system in breast cancer? Of these five, 1, 2, 3, 4, 5.
Spine tenderness.
No, most commonest is respiratory.
Lungs, okay.
Lungs. Why? What findings you can expect there? So in other words, what metastasis is you expecting lung in carcinoma breast? Is it parenchymal? It is pleural? It is solid? It is liquid? Or it is gas? What type of metastasis you expect?
Pleural.
Pleural. So pleural effusion. So what type of,
Effusion.
what is the finding in pleural effusion?
Dullness.
What
Decreased
dullness?
breath sounds on
Yeah,
auscultation.
yeah, decreased breath sounds. What dullness? Specific dullness is there? What dullness?
Yes,
You're seeing the roof. Previously, we used to have stony roof.
hard.
Yeah,
Stony hard dullness.
Stony hardness, stony dullness.
Stony dullness. Okay.
So what is actually stony dullness?
The sound of the while percussing. The sound of the percussion, it is feel like a
So dullness
percussing.
and stony dullness. When you do a percussion on the stony dullness, you will feel the pain on your finger. So that is stony dullness. So if you have percussed stony dullness once, you will never forget it.
Okay.
Okay, that is called stony dullness. It is classical feature of pleural effusion, and pleural effusion is the most commonest clinical manifestation of metastatic breast cancer. Okay.
Okay.
So
Sir.
that is a thing which you have to include even in the breast examination itself. We can mention also.
Okay.
Okay.
Okay. Sir.
And is there anything next?
Mammogram image and summary, sir.
No, that is our investigations. Come to the summary. Yeah.
Summaries. Summary on summarizing: 70-year-old postmenopausal female presented with lump in upper inner quadrant of right breast, which was approximately 4 x 4 cm in size, painless, hard, mobile, with no skin or chest involvement and no axillary lymph nodes. My probable diagnosis would be right breast carcinoma with the clinical staging of T2, N0 and M0.
Okay, in this final summary, never mention this approximate and all. So we have done all the examinations to confirm all our findings. So you need not mention this approximate and all, okay? And you again mentioned the histological diagnosis. So what is the other differential diagnosis?
Differential diagnosis would be fibroadenoma or fibroadenosis
In
with
70-year-old postmenopausal.
Sir, other or any benign tuberculous breast lesion, tuberculosis of breast.
Have you heard of any other malignant tumor in breast other than carcinoma?
Paget's disease,
No.
which would be more profound, sir.
Paget's, it's again carcinoma only, or you will feel an ulcer in the nipple areola. So you mentioned N0. So
Yes.
even in that tumor, there will not be any N0. Any leaf-like tumor?
A phyllodes tumor.
Phyllodes tumor.
Phyllodes
Phyllodes
tumor.
tumor
Yes,
can
sir.
come in any age. Okay.
Yes, sir.
So phyllodes tumor, if it is a malignant phyllodes tumor and angiosarcoma and all, they can come in any age. Okay.
Okay.
So I think other examiners might be waiting to ask questions. Sir, Rohit sir, you can go ahead, sir.
Yeah. Any spectrum of Andy which can appear at this particular age group? What do you mean by Andy? A and D?
Yes, sir. Developmental.
So you wanted to discuss only
Things,
malignancy, read Andy.
No, sir.
What is long form? Andy? Aberration in normal development and involution.
Normal
So any
development.
spectrum of this Andy can happen at this age group?
Fibroadenosis.
70 years.
Don't know, sir.
What all three diseases are there? That will be your differential diagnosis. What sir wanted to ask. Yes. And again, when you mention about it, yes, this is hard and mobile. Mobile with no. Again, mobile will take you to the other differentials. Let it be restricted mobility.
Okay, sir.
Again, if it is something which is fixed to the breast tissue, then it will raise a suspicion of malignancy. Completely mobile, painless lumps can take you to the benign. So when you give a summary, also let it be, a better tailored to focus on that particular diagnosis.
Okay, sir.
Okay. So fine. Again, and the last case also overtelling. Try to mention it as right burst malignant lump, rather than giving a histopathological diagnosis as a carcinoma, adenocarcinoma straight away.
Okay, sir.
Okay.
Malignancy.
So you had a T2, N0, M0. How will you proceed
sir.
with your triple assessment?
Mobility. What mobility you are talking about? Individual mobility of the lump or lump moving with respiration, breast tissue?
Lump, individual mobility of the lump.
Usually,
Okay, sir.
when there is a discordance in your findings, you should little be careful, because here you say hard lump. Usually hard lump will not have independent mobility.
Okay, sir.
If you have both together, then it can be there, but you should be very clear and you should be rationally explaining that. Got my point?
Yes, sir. Hard lump.
Hard lump, hard mobile lump. Where is it? Where it can happen? Hard mobile lump. Usually hard. Okay, I agree. If it is near the skin, it may be hard. Is it near the skin or deep inside the breast?
Deep inside the breast, sir.
Then it cannot be hard. Overlaying breast tissue will reduce the hardness, feeling of hardness. Overlaying breast tissue will be there. Usually better.
In other words, hard and mobile will never go hand in hand. If it is hard, it cannot be mobile, and if it is mobile, it cannot be hard.
Yes. Okay, sir.
So, as Rohit sir told, you have to mention it as hard with restricted mobility. No.
Okay,
hard with restricted mobility. So that will be better.
Okay, sir. Okay,
so
sir.
what Sir was asking again and again, mobility is with the skin, mobility with the breast tissue, and mobility with the muscle. So you have
Chest wall.
mentioned it is separate from skin and muscle, but it is
Chest
fixed
wall
to
is
the breast tissue.
breast
So if it
tissue.
is fixed to the breast tissue itself means it has a restricted mobility.
Mobility.
So
Okay,
you
sir.
already mentioned that.
Yes, sir.
It moves with the
Okay,
breast
sir.
tissue, right? So you mention it as
Yes,
a
sir.
restricted mobility. So that will
Okay, sir.
come. Yeah, yeah.
Okay, sir.
But when it will not move with breast tissue, why you should say mobile or not?
Sir, why? I can't get, sir.
No, there are two entities,
Yes, sir.
moving with breast tissue and independent mobility.
Yes, sir.
Agreed? There will
Yes,
not
sir.
be independent mobility when it is hard.
Yes, sir.
Why should you bother about that tumor, the lump moving with breast or not? Because if it is fixed to underlying pectoral fascia or pectoralis major muscle,
yes, sir.
It will not be mobile. Particularly so when the muscle is put into contraction.
Yes,
And
sir.
if it is fixed to skin, it will not move. It may move along with skin, but it will not move without the skin. And the answer for the other question was ductectasia with pigmented mastitis is the differential diagnosis for malignancy in elderly individual, and that is more common.
Okay, sir.
Okay, proceed.
There was little mention about a mobility only. Let's continue with that. Can you, like, there is a test to do that. Pectoralis major, if it is involved, then it can be there. Can you find out in examination that is it fixed to the clavipectoral fascia, that is pectoral fascia, superficial to the muscle? You got the question?
Yes, sir. Pectoralis fascia is involved on putting contraction to the muscle. I can check the motility
before going it, because that forms a very tough barrier. It will not allow easily to go in muscle. Muscle is infiltrated, you have a test. You put hand on the waist, ask the patient to contract, all those things. But if before that, if it is infiltrating into just clavipectoral fascia, not gone deep yet, can I find out? Not in the book. Again, you ask the patient to raise the hands. Move it.
Raise the hand. Yes,
ask
sir.
the patient, put clavipectoral fascia completely in the tense position, and now you can check it. Right?
Okay,
All three. Depth by depth you can do. Breast tissue, clavipectoral fascia, pectoral muscle, and chest wall.
Okay, sir.
So the clue is
mobility is a very important test.
Yeah, you can put muscles into contraction and fascias into stretching.
Stretching. Okay, sir.
So you can stretch the clavipectoral fascia by raising the arms.
Okay, sir.
So as sir told, with the clinical examination itself, we will know from skin up to the intercostal muscles, up to the chest wall, where all it is fixed. So everything you can know with the proper clinical examination.
Okay, sir.
Proceed with triple assessment. What you will do next?
After my clinical examination, I'll confirm, go for a radiological imaging for confirmation and core needle biopsy for completing my triple assessment, sir.
Radiologist offers 5 methods. MRI is there, PET scan is there, CT is there, mammo is there, USG is there. What do you want to take?
I would do a mammogram in this patient, sir.
Which breast?
Both breasts.
Yeah. How many views?
Craniocaudal view and mediolateral oblique view, sir.
Okay. What are the things you will see?
I will look for any lump, impalpable lumps seen in the mammogram.
No, number one, already the lump is there, no? First we'll see the lump, right? There is a lump already.
Lump.
So you'll see the lump.
Yes, sir.
Whether it is correlating with your clinical features.
Yes, sir.
Then?
I look for calcifications, microcalcifications.
Okay. What other calcification will be there in elderly? 70 years? What is the commonest calcifications you will see? This is a vascular calcification. So all the vessels will be calcified. Okay, you can easily, beautiful vascular calcification pattern you can see. Next.
Okay, sir. Any other swelling or impalpable swelling or nodes present, sir?
Okay. Nodes. You mentioned no nodes. So what are the nodes you will see? Can you see nodes in the mammogram? So you have a mammogram here. Put it. So where is the node here? Can you show me? Where is the node here?
Not seen.
Not seen. It is very much seen there. I thought you
Sir,
are going there. Suddenly you told not.
Yes, sir.
It's very
No,
much
sir.
seen. You can see
Yes,
that.
a mediolateral oblique view. I can see a node.
Yeah. Both are mammogram only. I am just asking
Yes,
that
sir.
one. Yeah, that is the node. Okay.
Yes, sir.
So only in
Yes.
very bulky breast or improperly taken mammogram, you will not able to see. So here it is beautifully seen, the node.
Yes,
Even
sir.
it is irregular architecture, everything is perfectly seen. Okay. And you can see
Yes,
the
sir.
mass, and you can see all the vascular calcifications. You
Yes,
can
sir.
see the muscle line. It is how much away from the muscle, how much away from the skin. Everything is given clearly.
Okay.
Okay. And what about the normal other side, contralateral? Why do you want to take the contralateral?
To compare the diseased breast and also to rule out any other contralateral suspicious lesions.
Yeah, that's right. But what I am seeing is there are nodes on the opposite axilla also. Clinically, is it N0 only?
Yes, sir.
Both sides?
Clinically, it was N0, sir. On
Okay.
mammogram, you can able to see the node.
But I can see some nodes here also. Opposite axilla in the MLOB, there is some amount.
Yes,
I
sir.
see some. Yeah.
Yes, sir.
So next, what is the next investigation? Mammogram taken. It is mentioning a mass effect by Rats 4B.
Okay.
So I don't know what is mentioned there. By Rats 4B. What is meant by Rats?
Okay. Breast imaging reporting and data systems.
So what does that mean? If it is 4 means what?
4 is suspicious of malignancy, sir.
Highly suspicious
Malignancy.
or just suspicious?
Suspicious of malignancy, sir.
So if it is 3?
Probably benign, sir.
Probably benign. That means it is probably malignant also. It is like 50-50.
Probably benign is no evident classical features of malignancy present, since it is considered as probably benign. Virat's 3, sir.
Okay, here it is Barrett's 4 now, correct?
Yes, sir. Yes,
Have they
sir.
mentioned anything about the nodes?
Sir?
In the mammogram report, have they mentioned anything about the nodes?
Yes, sir. There were one node present in the anterior axillary node present.
Yeah, you're able to see that also. Okay.
Yes, sir.
So what is the next? So you're having the mammogram in your hand. What is the next investigation you want to do?
I would go for a core needle biopsy, sir.
Okay, from where?
Biopsy over the lump, upper inner quadrant.
Excellent.
Lump.
Okay. So what are the things you want to do?
I would advise for a true cut biopsy, sir.
Yeah, core needle biopsy is true cut only. True cut is the company name. So core needle biopsy is the correct answer. So have you done a core needle biopsy?
Yes, sir.
Yeah, tell me the procedure.
After getting consent from the patient, I'll lie her in a supine position with arms abducted and exposing the breast and axilla. I'll sterilize the area and I'll explain the procedure to her, how we'll take a sample and then I'll give a local infiltration of local anesthesia over the site where I'm going to take the biopsy. And I'll take a 11 blade and make an incision, stab incision first.
Where? That is the most important question. Where? Lesion is 12 to 2 o'clock position.
Yes, sir.
And it is close to the nipple areolar complex.
Yes, sir.
So where you want to make the incision? exactly over the summit of the tumor, or close to the nipple areolar complex, or 12 o'clock position, or 2 o'clock position?
Over 12 o'clock position, I'd make a.
Why not in
Yes.
1 o'clock or why not in 2 o'clock position? Why not close to the nipple areolar complex? No, is it important or what do you think?
Yes, sir. Close to the nipple areolar complex, I would not prefer due to a chance of injury to the underlying.
What underlying structure is there? No, it is always prudent to do the biopsy from the summit of the lesion, so that minimum amount of normal breast tissue gets contaminated.
Okay.
And never go close to the nipple areolar complex. Many times, sometimes some surgeons go along a periareolar incision and do some breast tunneling and reach the tumor during surgery. So that is not advisable. Whenever there is a clinical diagnosis of malignancy, always take a biopsy close to the summit of the tumor. Okay. So you make a stab incision, take a biopsy. How many cores you want to take?
I would take for 4 to 6 samples.
4 to 6 samples. Excellent. So what needle, what size of the needle you use regularly in your hospital, Lotus Hospital?
I would go for a 16. What?
16 what color? What is the color of
Pink
the
color, sir.
Okay.
Pink.
16 or 14, which is good for you? Which will be thicker? 14 or 16, which is thicker?
16 is thicker.
14 is thicker.
Okay.
As the number increases, it becomes more thin. Okay.
Thin. Okay.
So
Okay,
if it is very hard, no, when you are mentioning very hard lump like that in your clinical feature, if you use 16 or 18, the needle will bend and break. So go with the thicker needle. 16 or 14 you go. Okay. So take as you told 6 to 8, and how you will send it? Fresh saline, normal saline, 3% NaCl, formalin, formaldehyde. How do you send?
I will. Saline is used for container, sir.
Okay.
Container filled with the saline, and I'll send for histopathological route.
So it will get. What will happen if you put any tissue in saline after 1 day or 2 days? It will decompose.
Discolor, sir.
So how you will send then? How you normally send for pathological specimens?
Formalin is sir.
10%
formalin solution. 10%.
10% formalin, undiluted. It comes in 10% only, so you don't dilute it. Undiluted 10% formaldehyde. Formaldehyde and formalin are both same only. Okay.
Okay.
So you know the formula for formaldehyde?
It's ethyl.
It is formal. HCHO. If you have seen the bottle, you will never forget. HCHO. Okay. HCHO. Okay.
Okay.
So you know the smell of formalin.
Yes, sir.
You smelled it, right?
Yes, sir.
So you have to mention clearly it has to be put in formalin immediately. And there should not be any delay. Why it is important? If you delay, what will happen?
To prevent the decomposition and exposure to the oxygen.
No, not that. If you don't put it in formalin immediately, when you do a immunohistochemistry on those true cut samples, okay, the validity gets lost.
Okay, sir.
Okay, so you have to put it immediately.
Okay, sir.
And fixation has to be for 48 hours.
Okay, sir.
So, okay. So now the true cut biopsy you have sent. The core cut biopsy comes as infiltrating ductal carcinoma, NOS, grade 2. What does this NOS means?
No other specified type.
Okay, not otherwise specified. Yeah, not otherwise specified. Okay, grade 2.
Yes.
So you want to know any other extra information from this?
Yes, sir. I would like for hormone status.
Okay. No, that is immuno findings. Any other histopathological findings you want to know? Other than this thing, infiltrating ductal carcinoma is there, NOS is there, grade 2 is there. Any other information you want to know?
Well differentiated or poorly differentiated?
So that will come under grade. So you will know about any other DCAs is there, associated DCA is there. Okay. Any other fibrosis is there. And other than that, you can know the receptor status. So what are the receptor status you will see? IHC?
ER/PR and head to new status I would look for.
So always in examination, try to avoid abbreviations, okay? Because not many examiners will like abbreviations. So what is ER, what is PR?
Estrogen and progesterone receptors and head to new or...
Okay. So any other thing you can see? Any proliferative markers you can see here?
Index of K index
KI?
can be checked.
Some number is there, no? What is KI?
K67 index can be. Yes, sir.
Okay, it is ER positive, progesterone receptor positive, HER2 0.
Yes,
okay.
Sir.
So mammogram finding is there. This is there. Now what is the next line of management?
After confirming the diagnosis with the...
Confirmed.
Yes, sir. Confirmed.
Diagnosis
Yes, sir.
confirmed.
Yes, sir.
Next what?
I would advise surgery for the patient, sir.
Okay, so you are doing surgery. After surgery, patient tells that is some breathing difficulty. You auscultate. There is a big pleural effusion. What you will do? So, in other words, how will you confirm that there are no other metastases anywhere?
Yes, sir. For staging workup, I would go for a CT or PET CT. Sir.
So for any malignant case, first step confirmation of diagnosis. Second step is metastatic workup. Never forget it. Okay. Never forget it in examination. Never forget in your practice. So metastatic workup. What are the metastatic workup in a 70-year-old elderly male with 4 into 4 centimeter medial quadrant lump?
CT chest. So I would advise CT chest.
Yes.
This patient for rule out.
So what are the things you want to see? What are the things you will see? What are the things you want to see?
In chest CT, sir?
Yes.
In chest CT, there is no other focal lesion in the lungs, sir.
Okay.
I look for pleural effusion.
Yes.
And any other internal mammary lymph nodes, enlarged lymph nodes.
Excellent. Excellent. Next. What else you can see? You can see the spine also, no?
Yes, sir.
Spine will also be seen in the CT chest.
Yes,
so what
sir.
So you can see for any metastasis in the thing. So any other metastatic workup you want to do?
I would additionally add a liver profile to look for increased alkaline phosphatase level.
That is for bone metastasis or liver metastasis?
Yes, liver metastasis.
Liver metastasis.
Both.
So, okay.
Alkaline phosphatase, I look for bone metastasis, sir.
Okay. For liver? If there is liver metastasis, what you will see?
Any organomegaly can be seen with deranged LFTs, sir.
Which organ you will be enlarged in liver metastasis? Pancreas? Kidney?
Sir?
Patient is having liver metastasis.
Okay, sir.
You wanted to look for any organomegaly, no? Which organ you are expecting to be enlarged?
Liver, hepatomegaly, sir.
Hepatomegaly. There will be metastatic growths.
Okay.
Parenchymal liver metastasis. So what is the investigation you want to do here?
PET CT, sir.
Directly?
PET.
Directly you want to do PET CT? A simple ultrasound is sufficient. So USG will give us what are the details you will know with the USG abdomen, ultrasound abdomen in this patient.
Ultrasound abdomen, I can see organomegaly, any ascites present, sir.
Yeah, ascites. Then liver enlargement or liver metastasis.
Yes, sir.
You can see for any ovarian enlargement. So that's why I was again and again asking you mentioned about sterilization. Sometimes some people are sterilized with hysterectomy, along with that oophorectomy would have been done. So you can see the ovary status also here. And also any intra-abdominal nodes if it is enlarged. If you have any suspicious lesion, you can do a CT abdomen also.
Yes, sir.
So this is sufficient. PET CT is not needed in this patient. So CT chest, CT abdomen, no metastasis here.
Okay.
So diagnosis confirmed, non-metastatic. So it is T2. It is now N1 or N0. What do you think? With the mammogram showing clear cut
N1,
node
sir.
is here. So it is N1, M0.
N1.
So what treatment you want to offer for this patient?
With T2, N1, and M0, patient comes in early breast carcinoma, sir. I would advise, I would give her the options of breast conservative surgery and a modified radical mastectomy.
Why are you giving an option? Which is better of the two? Which is better of the two?
Modified radical mastectomy, sir.
Why?
In a 70-year female, I would advise her to go with the modified radical mastectomy.
Yeah, that's what. Why?
For prevention of recurrence.
So why don't you remove the opposite breast also? You can remove the other side also to prevent recurrence.
The lymph node metastasis, ipsilateral lymph node metastasis can be avoided for metastasis, further
No,
metastasis.
no. That's not the answer. So you give an option of breast conservation surgery only. In an early breast cancer, the treatment is gold standard is breast conservation surgery. If you think modified radical mastectomy is better than BCS, then why not offer radical mastectomy? Radical mastectomy is still better, right? It's not so. Oncologically, both are safe. So you give the least cosmetically deranging surgery. So breast conservation surgery for all EBCs, early breast cancer. So how do you do a breast conservation surgery in this patient?
Wide excision of the lesion plus lymph node clearance followed by radiotherapy, sir.
Any role of sentinel lymph node in this patient? Lymph node is palpable now.
Since lymph node is palpable, I will go ahead with the axillary lymph node dissection itself, sir.
Okay. So how will you do the breast conservation surgery? Explain the procedure.
Elliptical incision, including the lump and the nipple areolar complex is made, sir.
Nipple areolar complex also. Why?
For adequate margins, I will include 5 centimeter from the lump, sir.
5 centimeter. The entire breast will be engulfed. So what is the margin for breast conservation surgery?
1 centimeter.
Yeah, 1 centimeter is sufficient. You have seen a breast conservation surgery in your hospital?
Sir.
Yeah, it is only 1 centimeter. Okay.
1 centimeter.
And there is no need to include skin ellipse at all. So if you want, you can include the skin ellipse just for the margin sake. Okay.
Yes, sir.
Then how deep you go? Deeper.
Yes, sir. Till the pectoralis major muscle, I'll go, sir.
Okay. You take 3-dimensional clearance.
Yes, sir.
And send the specimen.
Yes, sir.
You want to send the specimen or not?
Yes, sir.
Yes.
I would like to send the specimen.
Before sending the specimen, you have to tag the specimen.
Yes, sir.
Okay. Then axilla. What you will do? How you enter the axilla? From the wide
by
excision?
Dividing.
From the wide excision, or you want to put a separate incision?
From the wide excision, sir.
So from there itself, you will tunnel and reach the axilla. So if it is a upper outer quadrant lesion, you can go. But if it is an upper inner quadrant, it is not at all possible, and it should never try like that. You have to put a separate curvilinear incision near the axillary fold, anterior axillary fold. Okay.
Okay, sir.
And do the axillary dissection separately. So what are the groups of lymph nodes you will remove in axilla?
Level 1 and 2 lymph nodes.
Okay.
Removed, sir.
Okay. So only the lymph nodes you remove, or anything else also? It is the lymph nodes, lymphatics, fat, fascia. Okay, everything is removed. So if you think there are multiple significant nodes, you go even up to the level 3.
Okay.
So how do you surgically classify the levels of the lymph nodes?
Levels of the lymph nodes are divided by the pectoralis minor muscle, sir. Lateral and inferior to the pectoralis minor is level 1 nodes. Between the pectoralis major and minor muscles is a level 2 nodes, and above pectoralis minor muscles is a level 3 nodes.
So level 2, come again?
Interpectoral nodes, sir.
No. It's not so. That's what I'm telling. It is not between the pectoralis major and minor. It is deep to the pectoralis minor. Okay. So all the nodes are, which is lateral is level 1, posterior is level 2, medial is level 3.
Okay, sir.
So how do you reach the medial group? That is the level 3 lymph nodes. How do you visualize? So the pectoralis minor is hiding the nodes. How do you visualize? Pectoralis minor is there. How you will visualize the group 2 and group 3 nodes during surgery?
Retraction of the pectoralis minor, sir.
Yeah.
Pectoralis minor is retracted.
Yeah. Have you assisted axillary dissection?
Yes, sir.
So what is how you retract? What instrument you use to retract?
Langenbach's retractor.
Yes, you use Langenbach. So what is that? What is that technique called? So all these are modifications of basically what mastectomy?
Patty's modified radical mastectomy. Yes,
so
sir.
of that there are some 3 subtypes.
Yes, sir. Auchincloss modification of.
So Auchincloss, what is Auchincloss actually?
Auchincloss is where the pectoralis minor is retracted and
Very good.
lymph node clearance is given.
What is the modification called when you remove the attachment? Detach the attachment of the pectoralis minor.
Patty's classification is removed. Pectoralis minor is removed.
No. Patties is for no. We don't remove minor. In patties, we don't remove minor or major. Okay, both are there. What I'm asking is when you are doing an axillary dissection, when you are detaching the pectoralis minor insertion from the bone, where is pectoralis minor inserted?
Coracoid process.
Excellent. Coracoid process of which bone? What is that bone called? Scapula. So when it is detached, it is called Scanlon's modification of Patty's mastectomy. Okay. So what we routinely do is Auchincloss. So surgery over, you have removed the lymph nodes. So you want to close or you want to keep drain?
I want to keep drains.
Where? Both areas or only in axilla or only in the wide excision area?
Both axilla and excision area.
Okay. In breast conservation surgery, whenever you are going to allow the wound to heal by seroma formation, don't keep drain in the wide excision area. Only in the axilla you keep the drain. Okay. So now you send the specimens again for histopathological examination. In what material?
Yes,
what is the thing? Saline?
Formalin.
Same. Okay. You have to send.
Formalin.
Now you wait for the histopathological examination. So final histology comes as PT2 N1 M0. 2 out of 16 nodes positive. No extracapsular spread. Tumor is 2.5 into 2 centimeters. All margins free.
Okay.
So what is any other management is there or surgery sufficient?
I look for the hormone status.
Yeah, we already saw that. It is ER/PR positive, HER2 0. We already knew that.
Yes, sir. In hormone positive, ER/PR positive, I would advise for a tamoxifen selective estrogen receptor modulator.
Patient is 70 years old. So you want to give tamoxifen?
No, sir.
What do you give?
Aromatase inhibitor like letrozole.
What is the dose?
Anastrozole.
Letrozole, what is the dose?
No, sir.
Okay. Before giving that, you want to give any other local treatment for breast conservation surgery?
Followed by radiotherapy.
Radiotherapy is must.
Yes.
Okay. So before that, any chemotherapy in this patient? So for this
Yes,
patient,
sir.
chemotherapy is there, but since she is 70 years old, we can
Okay, sir.
have a tumor board discussion, multidisciplinary team. So which will decide whether we are going to give the chemotherapy based on the pros and cons. Not neoadjuvant. Surgery is over.
Okay.
Once the surgery is
Okay.
over, there is no role of neoadjuvant. Okay. So
Okay,
then
sir.
you give radiation. Then
Okay,
that is
sir.
followed by aromatase inhibitors. Since there
Okay,
is
sir.
no HER2 new is negative or zero, there is no
Yes,
role
sir.
of targeted therapy.
Transisome.
Trastuzumab, it's not needed.
Yes, sir.
Sir, any
Okay.
other examiner, sir? I think I have taken long time. Sorry.
No, sir. Say, it is your diagnosis is early breast cancer. Only one question. What are indications
Yes,
you
sir.
want to give neoadjuvant chemotherapy for these early breast cancer cases? And part B of the question, when you want to do MRM for this case?
Neoadjuvant chemotherapy for axillary, I'd give a neoadjuvant chemotherapy and look for axillary clearance.
In the same case, you presented a case as T2 N0 M0. In mammogram,
Okay.
suppose you found out that is N1. So it is still early breast cancer. So is there
Yes, sir.
any particular indication in this where you want to give neoadjuvant chemotherapy, though it is a ABC? So the answer remains it is triple negative disease. If you find out a receptor status, you find out triple negative, you go ahead with a neoadjuvant chemotherapy rather than directly going with it.
Okay, sir.
You want to do MRM for this case. Can you justify? I want to do MRM. Can you justify that? Okay, why I want to do MRM for the case, though it is ABC? Again, basically, seeing her performance status, 70 years she is. I don't want to give a radiation to her postoperatively. Because EBC comes with radiation therapy. If I don't want to give radiotherapy, give option of MRM.
Okay, sir. Okay, sir.
Then MRM, axillary dissection, and then we can proceed. So
Yes, sir.
okay, fine. That should be good discussion.
Okay,
Yes,
sir.
sir. Lastly, can you tell me borders of axillary dissection, borders of MRM? What should be borders of this?
From laterally till exposure of latissimus dorsi muscle, sir.
Okay.
Medially till lateral border of pectoralis minor and also the lymph nodes, level 2
What do you
lymph
mean by
nodes.
Halsted ligament? Medially, it is
Yes,
Halsted ligament. Laterally, lateral border of. Then inferiorly?
Inferiorly up to the angular vein.
Very good.
Thoracodorsal pedicle converging into angular vein, sir.
Right. Superiorly?
Superiorly, antero-inferior to the axillary vein, sir. Should
Right.
not go beyond the axillary.
Breast dissection now. Borders of breast dissection. MRM?
In modified radical mastectomy, superiorly till the clavicle, sir.
Okay.
Medially till the lateral border of sternum.
Right.
Inferiorly till the inframammary fold 2 centimeter below, sir.
Till the insertion of rectus you see. And then laterally?
Yes, laterally till latissimus dorsi muscle.
Okay, that is till you wanted to go till that point. That is including axilla. If you go for it. Right. Fine. So if you want to, you have done this. Suppose MRM for this case. Till you want to give chemotherapy. Again, depending on the performance, as sir was also telling. Yes.
Okay, sir.
You can discuss in a tumor board and take a call on a chemotherapy.
Okay, sir.
Okay. Because
okay,
70 years, seeing her performance status, seeing her life, what she has, have to take a call. Otherwise, textbook wise, you have to give chemotherapy for all the cases.
Okay.
Right.
Okay, sir.
Fine. Again, in ultrasound, you mentioned about ovarian size or something. Do you expect Krukenberg tumor for this lady?
Yes, sir. In ovarian malignancy with pleural effusion,
No.
Can suspect.
Question is very straightforward. Do you expect Krukenberg tumor for this case?
I think you got confused with Meigs syndrome and Krukenberg's. This is not Meigs.
Okay.
Sir is asking about Krukenberg's. Krukenberg's, it's solid bilateral ovarian tumors which can come in stomach or any GI malignancy or breast. So can it come in this age? He's asking.
Age, no, sir.
It should be reproductive age group.
Yes.
So what is there in the reproductive age group to produce Krukenberg's tumor? What is there?
Estrogen.
It should be a fertile ovaries.
Yes, sir. Estrogen.
Fertile seed. That's it.
Lot of scarring because of frequent ovulation.
Okay.
Right. And one last question. Now, as you are giving chemotherapy, what forms the backbone of a chemotherapy for solid organ tumors, particularly breast cancer?
Name the drug. What chemotherapy drug you give?
Cyclophosphamide, adriamycin, and 5-fluorouracil. So.
Choose one drug out of it, which forms the backbone of this chemotherapy. Random choice.
Nowadays, we don't use 5FU. So that choice is gone. Phone a friend is okay. So you got 50-50.
Cyclophosphamide.
Okay, that is also gone. Which is remaining now? Adriamycin.
Okay, sir.
So of adriamycin and doxorubicin, which is good for breast cancer? Which is good, doxorubicin or adriamycin?
Don't know, sir. I'll refer it.
There is no need because both are good. Because both are same drug only. Adriamycin and doxorubicin both are same. Okay.
Okay, sir.
So read something about chemotherapy drugs also. I think we have not much time. Yeah, so we cannot discuss more, but they may ask. So how many MRMs or breast cancer conservative surgeries you have assisted? You are in second year, right?
Yes, sir.
How many surgeries you have assisted?
More than 20, 25, sir.
Then you should be well versed with the surgical anatomy.
Yes, sir.
Okay. Yeah. Okay, sir. Any other examiner, sir? Sir Subhaya, sir? Kanagavel, sir?
Yes, sir. Should allow the candidate if she has any doubts to ask Arpita. Like you have any doubts to be clarified? After preparing for the exam, do you have any specific areas you would like to get clarified?
Sir, still I have a doubt now we will give her a chance of breast conservative surgery or
So all early breast cancers, surgical management is breast conservation surgery unless the patient herself wants, not the family members, herself, irrespective of the age.
Okay, sir.
Age is not a determining factor to offer complete radical mastectomy. Doing MRM is like amputating your hand for an ingrowing toenail. Amputating the entire foot. Okay, it's not advisable. Okay.
Okay, sir.
So always it is for early breast cancer. It is
breast conservative.
Except if the patient cannot undergo RT, as are told, because radiation has to be given. RT cannot be given. Then only you have to go for MRM. Okay. Any other doubt you have? Okay, Arpit is there.
Any other questions, ma?
I think the other candidate has gone, sir. He's not here. I can't find him.
No, sir. Good evening, sir. I'm here only.
You're here. Oh, you have changed your name to an iPad.
Yeah, sir. Like it wasn't working.
Okay. Yes. So both of them presented well, sir. Kanagavel, sir. Both of them presented
well. Yes, sir.
And they did excellent job. I think both are in second years, right? Arpit, you are also in second year.
Yeah, I just entered the final year, sir.
Okay, great. So do well.
Entering into their final year, sir.
Very good. Do well. Both presented very well. I think all the other examiners also will agree with it.
Yes, and, definitely.
Fluent go. Yeah. Thank you, sir. Thank you.
Yeah. All the best, both of
Rohit, sir. Ibrahim, sir. Thank you. Students. Other faculty who stayed with us, especially Ishwamurthy sir. I think I could see you in the Zoom that long as we are there. And I thank all the faculty who have helped us to run the program today. And I wish you all the best. And we look forward for yet another week of PG clinics. Next week will be mostly vascular. We'll have varicose veins and arterial disease case. Thank you very much, sir. And good night, everyone. Good night, both the students. And thank you, faculty, for running the program today. Thank you.
Thank you,
Thank you,
sir.
sir.
Thank you, sir.
Good night. Good night.